I'm Lynn Cerillo. I'm a speech therapist across the street at JFK. I've been treating adult neurological populations for my entire career, which is 25 years. I spoke at the support group last year. I feel like people look familiar. Do you go to the support group?
No.
No? Somebody looked familiar to me. Anyway, I guess they asked for me to speak at the conference because they liked what I had to say, and so here I am, just to do kind of an overview of what speech can do for people with brain tumor. But one of the reasons that they enjoyed my talk at the support group was because a lot of times when people speak to people at conferences that have some kind of issue, whether it's stroke, head injury, brain tumor, they feel like people are just talking at them and they don't really understand what they're going through. They can't really empathize what the situation is. They appreciated my candor because I also have a brain tumor. When I started that talk, I said to them, I just have a little brain tumor, a little meningioma, and someone in the support group said, there is no such thing as a little meningioma, you know. So I will share for a few minutes with you guys what happened to me, and then we'll move on to the speech portion. But I had said to Patty, I don't know if I should tell them right from the beginning what, you know, my personal story, and then, you know, they'll realize that I, you know, can appreciate some of the situation, or if I should wait and shock them at the end after I, you know, tell them my whole stuff. And she said to do what I choose, and I decided to tell you at the beginning. So I have migraine, really bad, and so every 2 years my neurologist makes me have an MRI because I have some spots on the brain. She wants to make sure they don't change. In 2006, I had nothing. In 2008, there was a meningioma. So they decided to just wait and see if it, you know, would grow or not. 2009, it started to grow. Now, I realized that my little meningioma is not the same as, you know, other types of tumors. I'm well familiar with those because of what I've been doing for 25 years. But I thought you guys might appreciate a little bit of candor about me being involved with this, because I can appreciate not just on the professional side of treating people all these years with different levels of brain tumors, but the fact that, you know, having those little screws put in and the big halo, and I have pictures on my iPhone of, you know, looking like Hannibal Lecter with that special thing on, you know, that I can appreciate it a little bit. So moving forward, obviously with brain tumor, depending on the size, depending on the location, there can be speech problems and swallowing problems associated. I only gave you guys a few slides because, you know, you could do speech and swallowing problems associated with brain tumor for a full day. It could be a full day conference because depending on size and location, it could run the gamut of symptoms and what you do to help the problem. So I just wanted to do a little bit of an overview because most often the problem that comes first is swallowing. Usually it's very subtle, can be like a little bit of throat clearing. Usually with thin liquids comes more than solids, and that's even with other neurological problems, with stroke, with head injury, with progressive illnesses as well, like Parkinson's, Huntington's, things like that, Alzheimer's even, the gradual, it's usually something with thin liquids. And that's always because thin liquids are like air. They follow the path of least resistance. They move very quickly. So as the system of our musculature starts to slow down and be delayed in the swallow, the liquids still want to go as quickly as possible. And so while we're gearing up and setting up for the swallow, the liquids still want to go. So the thicker the liquid, the less likely that's going to go down the windpipe while you're preparing for the swallow. The thin liquid still wants to go. So usually thin liquids are what we have to restrict first. And so we would move to something like nectar thick and start to either thicken with a gel thickener, is something new that's out there that people are using. We have powder thickener, we have pre-thickened liquids. A lot of times people don't like that. Nectar thick is not so bad, it's just a hair thicker than the thin liquid. How we get to that point is you come in for a swallowing evaluation. Speech therapist tries the different consistencies for you, and initially it doesn't sound like our job is that much different than, you know, someone off James Street coming in and saying, oh, you're coughing on something, okay, you've got a swallowing problem. But other times it's a much more subtle assessment because it isn't always just you drink water and you're coughing and choking. Sometimes the symptoms are much more subtle. you throat clear a little bit. Your vocal quality after you drink a cup of water, you're not coughing, you're not choking, but every time you drink water, it's wet and gurgly. You sound like you're underwater. A lot of people don't realize that those are symptoms of swallowing problems. They just accept it as, oh, that's just me. I sound a little gurgly after I have a shake. After I have food, there's still food left in my mouth a little bit sometimes. After I eat solid food, a little bit of pocketing. Or sometimes, you know, if there's a little bit of muscle weakness on one side, a little bit of food comes out when I'm eating. These are things that sometimes the person themselves just starts to get used to and accepts, but doesn't really want to look at that I need a change. So speech will get in there. They'll assess with the different consistencies. Once we look at something like a liquid restriction and we're not really sure what's going on in here, we like to move to something like a modified barium swallow, which is just an x-ray test of the swallow. And that's where we can really see what's going on inside. And there you just have to sit in a chair in x-ray. The food and the liquid is mixed with a barium powder, and it's a lateral view of you. So we get to see exactly where the food is going. It takes the total guesswork out of the evaluation out of it, and we see if the food and the liquid is going into the windpipe or the food pipe. And then from that point, we can make the restriction based on whether you are aspirating or not into the windpipe. Aspiration is whether the food or liquid goes into the windpipe and eventually down to the lung. Now, the tricky part about the restrictions, okay, and this is depending on where on the level of people are with the brain tumors. For people that are very early on, people that are aggressively moving towards resolving the brain tumor, possibly curing, aggressively treating, I don't like to take any chances. I like to encourage them to do what they can to protect their lung status. And that is the decision always with the patient and the physician. If you're pursuing aggressive treatment, if you're in chemo, if this is your goal, then I try to encourage these folks to really abide by the diet restrictions. Because if you're going to take the chance and get an aspiration pneumonia, then you're not going to be able to tolerate your treatment. You're not going to be able to tolerate the type of doses that you're going to need, and then they might even have to halt your treatment if you get a serious enough aspiration pneumonia. So it's very, very important that if you're having swallowing problems, especially during treatment, and P.S., the treatment itself, if you had no swallowing problems going into the treatment, during the treatment, it can sometimes weaken people so much that it can cause like a temporary dysphagia. Sometimes people don't have a dysphagia problem, but during treatment they become so weak they start to have a little bit of trouble with thin liquids or with solid food. And they might have to have a diet adjustment during the treatment process, and then they can pop back to the regular diet after they've kind of recovered from the treatment process. So people that are further along, I'm sure you guys have friends or people that have had brain tumors that have advanced to a point that they can't do anything about. When it seems like there's a terminal case, and this is for people that have terminal cancer as well, people that are in end-stage diseases of other types. So I'm kind of addressing you even, I'm sure everybody knows someone that's had end-stage cancer of another type, end-stage renal disease, Parkinson's, that's the end stage. People that are 90 years old and just are having problems and say, look, I want to drink my coffee regular. I don't want any restrictions. I'm 90 years old. I've lived my life. I'm not drinking that thick crap, okay? Those are the people that I say, this is where you get to make a decision about your quality of life. This is where you say, is the risk worth, taking away my quality? And that is where the doctor, the patient and their family, and the speech person have to kind of all get on the same page of what is the most important thing to the patient. And it's a very important conversation to have. But you see what's involved. What's the direction of the treatment plan? What's the prognosis of the situation? What's the family and the patient feeling about what they want to do? So it's just a lot of a balancing act in terms of where everything is going. But the swallowing and the risk of aspiration is very important in that whole picture. And that's why it is important, if you start to notice that you're having those problems, to try to get in and see a speech therapist and at least just get an assessment, get a baseline, see where you're at in that situation. Does anybody want to have a comment about that, or anybody know anybody having any swallowing problems? Okay. So you understand what I'm saying about just that balancing act. Okay. In terms of speech, okay, again, sometimes the speech problems are very, very subtle initially, okay, and it depends where the location of the brain tumor is. Obviously, left side of the brain controls speech and language, okay, so if it's on the left side of the brain, that's where you're going to have a lot more problems as the tumor starts to grow. You can have, I just did one little slide in there, you could have dysarthria, which is slurred speech. You can have actual aphasia-like symptoms, which is difficulty with your language production, speech problems, articulation, getting the words out, just trying to keep it, you know, simple. Cognitive problems also. On the right side of the brain is more cognition, but that doesn't mean on the left side you can't. Memory problems, thought organization problems. Now, a lot of people who are older are saying, yeah, okay, I can't remember, you know, what I was doing yesterday if someone asked me. I've got, you know, when I assess my patients sometimes, and I just was saying this to somebody yesterday, I specifically never ask my patients, so what's today's date? Because no matter where I am, if I'm writing a check, if I'm writing a note, I am always saying to somebody, what's today's date? And I feel like I cannot ask my patients a question that I cannot answer myself on a daily basis. So I do not do that. And you know, I can't say to people, it's my meningioma, because my meningioma is in a dead space in the middle of my brain. It's not pressing on anything. And then of course my friends tease me and say, oh, you've got dead space, empty space in the middle of your brain. That's Lynn, empty space in her brain. So I just can't ever remember the date itself. So I never ask my patients that. But they should know the month, they should know the year, things like that. So orientation sometimes will start to get a little bit skewed, things like that with the right side tumors. If a tumor in the back of the brain, that's where the visual is impacted the most, and you might have trouble with visual perceptual problems, just seeing in general, visual spatial, front, back, things like that. The front of the brain, the frontal lobe, controls the executive function. Okay, so sometimes with a big tumor in the front of the brain, people will have trouble with their filter, saying things that they don't really want to say. Like we all walk around in public and we see people, we pass people, and there's things we'd really love to say. But our frontal lobe filter prevents us from doing that, unless we have road rage, and then sometimes we just say it. And but most often, this filter in our frontal lobe keeps us from doing that. So like example, head injury, not brain tumor, but just to give you an example, on a head injury unit, a young 18-year-old has a car accident, has a brain injury, they have a frontal lobe injury. Those are the folks across the street who are on, you know, are killing their parents because they were, you know, nice, soft-spoken kids, and then they have this frontal lobe injury, and the parents come to visit them, and they're swearing and they're cursing, and they can't help it. Their frontal lobe is impacted severely, and this is what's coming out. So a brain tumor in the frontal lobe can do the same thing if it starts to get large and press hard enough on that area. Executive function does that. Executive function organizes for us. So what the brain does automatically for us, like right now I'm not thinking about what I'm saying, it's just coming out. My brain is organizing it for me. I didn't practice this talk, it's just, this is what I do for a living, so it's just coming out naturally. But if I started to have, you know, tumor pressure in the front of my brain, I'd really have to, like, I'd probably have to have cards, I'd have to have compensatory strategies, I'd have to really do manual things. And the example that I like to use is an airplane. Nowadays, pilots don't really have to fly their planes. They have a button, they hit autopilot. Obviously, they have to be present, supervising everything, but they have a button that's autopilot. So every person, their brain is like their autopilot. It is an amazing part of a person's body. It controls everything. But enter stage left, a brain tumor or any type of insult to the brain, and suddenly you have to start to do some things manually, depending on the size and the location of the tumor or whatever the insult is to the brain. So same thing with a plane. Suddenly if the plane starts to have a malfunction, problem with the landing gear. Now they have to manually crank the landing gear down before they get on the plane. No longer can you hit a button and the landing gear goes down automatically. Now they have to manually get the landing gear down. So it's the same thing with the brain. Those things that were so automatic, we got so used to those things being automatic, now it's like a tedious process where we have to really think hard about those things. Trouble getting those words out. Got to stop, rest, think, and then do it. Sometimes you have to actually walk away and leave it alone, because the harder you press to get the word out, it's like coming up against a brick wall, and it's even harder to get it out. You have to step away from it, and then sometimes it'll come with ease in terms of a word finding problem. Sometimes when it's hard to understand what someone is saying to you, the coaching goes now from the therapist to the listeners, not to the patient. A lot of our education goes to the families. A lot of our education goes to the caregivers if it's somebody that's in a facility. And we have to actually educate those folks and say, look, this is how you need to ask the questions. You need to ask in a yes-no format. You can't ask a question open-ended and say, hey, what do you think about those Yankees? Because right now, the patient doesn't have the toolbox to respond to that question. Well, this is what I think about the Yankees. You have to say, do you know if the Yankees won? Yes or no? That's that person's ability. Yes.
Can I ask you a question? You're probably going to get to this, but you're telling us the problems that they have now, the corrective techniques. I mean, if you keep working with them, do they rechannel in the brain? In other words, because my brother has a problem like what you've been mentioning, and I keep telling him that it finds different circuitry. It's almost like trying to teach a child when they're a baby, right? Mm-hmm. Is that basically the way it works? You can retrain them?
It's like relearning.
Is that the way?
But I think what more it is like...
Opposed to saying yes and no is what I'm saying.
Right.
Because that seems to me to be the simple way. You're not really improving anything. The question is, do you ever get them to a certain level? Is what it is.
Well, it depends, because if the pressure on the brain is in the same exact spot and it doesn't change, that impairment remains the same. So either you develop compensatory strategies to get around that same impairment, or you're kind of stuck. Okay. So unless the tumor is shrinking and relieves some pressure on that area of the brain that's impairing, or you have to find some other way around. Like sometimes if you can't, like sometimes we teach patients circumlocution. Sometimes people do it by themselves. Sometimes we teach it, which is talking around. So if they can't do yes, no, sometimes they can't get out what they want, but sometimes they can talk all around it. They can describe it, they can tell you about it, they can tell you what it's related to, but they just can't say what it is. Then that's where the listeners are educated and trained. That's where you've got to try to plug in the answers. Now, on the opposite end of that, it's sometimes extremely frustrating for the patient. If they're starting to tell you something and you're the person that lives with them and you fill in everything they say before they have a chance to even say it. And so it's a very tough balance, because they need a little bit of an opportunity to try to get it out, and it's hard for a spouse, a sibling, to know, when do I step in and rescue them because I think they're not going to get the word out, or when do I hold back and let them struggle and let them try to get the word out? So that's where it's sometimes very helpful to engage with speech therapy also, because the speech therapist can kind of be the medium person. And then the other thing is, and I'm so happy that I have somebody here in the room, there is alternative communication. If a person's receptive skills are intact, but it's their expressive skills that are impaired only, which is very often the case, there's alternative communication devices, things that they can use to express themselves. And this gentleman here is a representative for Lingraphia, which is one of the... So I'm going to let him just talk for a minute because... Huh?
I said I got my brother that. I said that.
Okay. Oh, wait, but 1 second. Go ahead.
I just have one more question on speech. So you're not telling us when we should interrupt and like give the word. You're saying, how do we know? You're saying we should go to a speech therapist to find that out?
Well, I mean, I think that because it's so personal for you, it might be helpful for you to bring the person for a speech evaluation, and then you go to speech therapy together. So if sounds like the person needs speech therapy, and then it sounds like together part of the whole speech therapy process is not just the speech therapy of the patient, it's the education for both of you. And then it helps you learn to communicate with your family member. Who is the family member for you? Right, so it helps you. Has she been to speech therapy? What is her problem? Is it word finding?
It's aphasia, but sometimes she can't say, like today she was trying to say red dress. That was like a tongue twister for her, and it's very hard for her to say.
And you know that's what she was trying to say.
Well, she did say it, but she'll repeat it a couple of times.
No pictures. I have snow hair. No pictures, I have snow hair.
I forgot that I have a brain tumor.
That's a lame excuse.
No speaking English.
But the real question I have, and this is what I don't know, she goes through stages where she'll be talking to her girlfriend on the phone for like an hour.
And it's fluent?
And she's great,
Mm-hmm.
and then all of a sudden she'll say, I can't talk to you anymore. And then she says, I have to hang up. And then she can't talk.
But that could be just fatigue. I mean,
So this fatigue, that was my question. Because I was asking one of the other doctors, and he said, well, maybe she has a TIA. And I said, no, I don't think so, because this happens very often. And then she like rests for half an hour. And
then she's
it's back.
better.
Yeah.
Yeah, a person can just fatigue also because they're trying so hard, they're spending so much energy. When a person with aphasia, like I just talked about the plane analogy,
Yeah.
you're not doing autopilot anymore. Everything is manual. Everything is a concerted effort. She's trying very hard. Sounds like she's fluent talking to her girlfriend, but that's all manual for her. She's thinking about what she's saying. Some of it's automatic. It's a girlfriend she's close with, she's known for a long time.
Right.
So a lot of that's automatic. It's not a new friend that she's having to make an effort, make conversation with. It's someone that is very comfortable with. And usually, with any kind of problem with the brain, everything that's automatic, everything that's simple, that's all stuff that's much easier and user-friendly for the people. So if she's talking, but even with that person, at a certain point, it becomes exhausting. And it's good that she knows her limit. It's good that she knows to be able to
She
say.
can't come up with words, and she knows. All of a sudden, her speech changes.
She
And
just
says,
has
"I
to
can't
step
think of
back.
any words." She
And
says,
she's-
I got to stop talking to you. I can't
Right.
talk.
And then if you're saying that after half an hour, then she's better,
Yeah.
then, because usually people with a TIA, they don't know it's coming.
Right. And they're not better.
It just happens.
Right, yeah, I guess.
I mean, a TIA does pass.
Yeah.
But most people, like when I see people over on the stroke unit, and you read the history, they've had multiple TIAs. They didn't know they were having it. They lose speech for a little bit. They have tingling, and they describe that after the fact, like the hindsight is 20/20. They didn't know they were having a TIA when it happened.
She knows she's losing her speech.
Right. So she's one of those people that has what I call the fatigue factor.
Okay.
And she knows that she has to step back. That's not like a high-tech term. That's a Lynn Cerillo term. Fatigue factor. Lynn Cerillo term. So then, see, that's her own. She's developed her own compensatory strategy. She knows. I better stop talking, or nothing's going to come out good. Quit while I'm ahead. Bye. I got to go.
Right.
You know? Now, if she couldn't get out the red dress, like when I say that a spouse shouldn't fill in every single word, if she's talking fine and she's saying, hon, I want that pointing to it,
Yeah.
We all do that. Hon, you mean the red dress?
Right.
That's okay. But if you've got an aphasic wife who's trying to have a conversation with you, let's say she's starting to get fatigued, she didn't do her own little alarm clock and say, I better stop talking, and she's saying to you, I want a drink of, I can't think of it. You say milk, okay, you fill that in. Then she starts to say something else. And you could tell she's getting frustrated with you. Like, let me try, let me say. That's when you have to say, okay, why don't we take a rest? Why don't we take a step back? Because if you fill too much in, you don't let them try to get it themselves, then it becomes like you're the therapy session.
No, she's not that bad.
Yeah. So then she's doing her own compensatory strategy. So you've got it made. Maybe she doesn't have to go to a speech therapist.
Well, okay.
Maybe you don't need me.
That's what I was wondering. Sorry.
Is that your point? Get out.
I know people have good jobs in this economy, but
I'm only kidding you. This is what I mean. Some people develop their own compensatory strategies. And so it works. Whatever works. Whatever
I
works.
mean, even when we're just talking, she'll say, I can't talk to you anymore.
And that is her strategy. Or that's just because you're a man and sometimes we get sick of our husbands. I can't talk to you. I'm sorry. My favorite show's on, right? Only a couple women in here, though. Oh, we're a little I just realized we're a little outnumbered for that comment. We better get a few more women in here for that. Was there another question? No? Okay. Okay, so I was going to have this nice gentleman here just for a few minutes talk a little bit about the Lynn Graphica.
I'll just keep it very brief. But my company makes software and devices for adults with aphasia. So There really, like Lynn said, there really are two approaches. One is compensatory, having trouble with word finding or word production. It's very frustrating. So these are talking computers in various forms, or software that you can download on an iPad, for example, and it'll talk for you. So those are like standard phrases that you might want to say, like greetings, or maybe a pain scale, so you can handle standard things as a doctor. Or customizable things. You can talk about your family, your pets, or the particulars of your illness. And then the other part is therapeutic. So you go to a speech therapist, but part of reacquiring speech requires lots and lots of practice, like every day. And that's where software can be a big help, because you can work on it every day at your own pace at home. And so, we do that. There are other companies out there. There aren't that many of them. Dynavox is the big company out there. They're always worth looking at. But there's right now on the App Store, there are hundreds of apps that will help you with both with speech production and on the therapeutic side. It's a lot to wade through. Sometimes, either a speech therapist, or there are speech therapists also who are experts in what's called AAC, augmentative alternative communication. That's a good thing to search in Google. So there's just a lot of tools out there. I just want people to know that. And, the devices are all covered by Medicare and insurance. The other things are much less expensive, but there's sort of a whole world of high and low technology equipment out there to help both on the therapeutic side and on the speech production side, and kind of the blending both. Maybe you're having a bad day, you really want more help on the production. You're having a good day, I'll say more myself, and maybe I'll work on it. But I think you were asking about sort of reassigning your brain. The big difference between learning language the first time as a child is you're using the part of your brain that was originally designed for language. Right. So everyone's language centers end up in roughly the same place. Well, after you've had a stroke, usually, or
brain tumor,
you're now going to try and reassign a different part of your brain to take on that function.
That's exactly what I was saying. The question is, does it work?
It can work, but it takes a lot of work.
Okay, so, repetition is what you're trying to tell me.
Yes, it takes a lot of practice, and it's a little bit of a use it or lose it. It's like, if you're working out and you get muscular beyond what you normally would be, you stop working out, you're going to revert to your old body. This is a little bit the same thing. It's not that you necessarily gain it and then you won't lose it. It takes lots and lots of practicing, and it's pretty constant. And there's some combination of that practice, the help of an expert. That's a great balance then to make. And what the studies do show, and this is I don't think was known necessarily 20 years ago, you can make progress forever. You can continue to retrain your other parts of your brain to rehabilitate the parts that were damaged if you work at it.
Right.
If you don't work at it, you'll make progress for about the first 6 months when the brain is, after either a stroke or a tumor has made some progress.
But the insurance companies aren't loving that piece of new news.
Right, and that's really, I think, a great point, which is insurance is really the opposite. They'll pay for a speech therapist during the period when you're making lots of progress. But that's because your brain is repairing itself. The time when you're needed, when you really need this person, is for the rest of your life. The insurance company, well, you're not making such good progress anymore, we won't pay for it.
No more.
But that is where some combination of software devices can really come into play.
And the only other thing about the augmentative communication is that you do need the receptive skills. So you need to understand, you need to have good comprehension, because you have to be able to select and use. So, even when we assess at a gross level, before we bring someone like this gentleman in to assess for an augmentative communication, I have to have my patients be able to identify pictures. Show me the shoe out of 4 pictures. After identification, okay, show me what you would pick if you had to go to the bathroom and they need to pick the toilet. So there has to be some sense of that they would be able to use the device functionally before you're going to even bring in somebody that's going to then start to assess with this device. But as long as there is some rudimentary comprehension skills that are intact, then the device is very helpful for someone that's lost the ability to express themselves. And then they try to facilitate, some more expressive skills with that. But I do find, even with my other populations, I work a lot with Huntington's disease also, but it just seems that all neuro populations are the same. Brain tumor is no different. Every neuro population is the same. People want to talk themselves for as long as they can talk themselves. And that is the truth, whether the speech is slurred, whether the struggle is hard, whether the words come out one at a time for a 10-word sentence, it doesn't matter. People want to talk as long as they can themselves. And that's where then a lot of the counseling comes in our speech therapy sessions with the partner, with the listener, with the family, with the caregivers in a subacute center, in a nursing home center with an older person who's being cared for there. This is how you have to respond to the patient. These are the kinds of questions you have to ask to get the right answer from your patient. This is how you can least frustrate the patient. So then it becomes, you know, a whole combination type of therapies.
I can't imagine how frustrating it must be for somebody that can't communicate, right?
Right. And especially when they know everything going on in here, but it just doesn't come out well.
Verbalize it.
I have a quick question for
Yeah.
you. So you said insurance, once you're not making any progress, it is not apt to continue with the treatment. But what is the argument, I guess, from a therapist side that even staying steady is progress, because were they not to be going to this therapy, they would go backwards? And so from a therapist point of view, like, can you help the patient with the insurance company in terms of?
Oh, let me tell you, we do some creative writing.
Just curious, yeah, to see.
Too bad that's on tape. Yeah, we do
can
some.
censor it, don't worry.
We do some creative writing as long as we can, but the standards are very difficult. And especially with some insurances, like, for example, outpatient speech. Insurance looks at the situation and then they dictate to us, okay, you have 11 visits, that's it. And then we'll be back to see what you have in writing of whether. So it's very strict for outpatient. Inpatient acute care, like when someone's acutely ill, like as an inpatient, it's a little bit, we can come as many times as we want. But outpatient, very tough, very tough. Subacute, there again, it's like an all-inclusive resort. You're, in a subacute setting and wow, I can have PTOT speech for as much as I want while I'm here. And then when you're out, it's a lot more difficult. Home care, that's also difficult. If you're homebound, when you first get out of the hospital and you're home, nursing can come to the house. But God help you if someone spots you out at the supermarket, you're in a lot of trouble then, therapy out. So it's, but I think that's because, and even, you see the news, there's so much Medicare cut now. I think that the systems were abused by a lot of people for a long time. And so now they've just come down with a major hammer. So we do try for people that are, then we're saying, well, there's some little bit of progress. There's still a little bit of progress for our people that are stable. So we try. As therapists, we try. We're never like so strict. Oh, that's it. We're not the ones going, that's it. So, and then we just try to really give you guys a lot of stuff to do at home. Because for sure, with the practice, with the doing stuff every day diligently that we give you to do, if you see twice a week or 3 times a week, if you're doing it every day at home, there's a lot of carryover. I can tell you this. When we take someone for a modified barium swallow who's failed a swallowing test, and they have, dysphagia, pharyngeal dysphagia in the throat, pharyngeal muscles. And then there's specific exercises that target those muscles. So I've had many patients that if they do those exercises every single day, special muscles that strengthen the base of the tongue, the muscles that are discoordinated for the swallow, and then they practice them every single day and we take them for another modified barium swallow, let's say 2 to 3 months later after they've had a feeding tube or whatever. A lot of times those patients then end up on a diet because they've done those exercises diligently, 5, 7 days a week at home with a partner, whatever, somebody coaching them, practicing them. Does it happen all the time? No. Does it happen sometimes? For sure. So those are the things too, is doing the carryover at home, because it really does help. But it depends again, where are you in the stage of your treatment? People getting chemo sometimes are so exhausted. The carryover is very, very difficult. You're saying you're getting no side effects of your treatment right now. That's really good. Are you, you're even fatigued, tired? Doing okay.
Just sees me, but no sign of the vaccine or the tumor.
Good.
Yeah.
Very good. Do you go to any therapies?
Speech seller, speech therapy. I have a lady that comes to my home.
Good.
And work in Westchester.
Westchester.
Western New York. For PT and OC.
Oh, great. Good.
We've done acute inpatient, outpatient, we've kind of hit all.
You've had it all.
Hit all the big ones.
So I saw you nodding a lot every time I talked about each service. Oh, I'm getting the boot.
Well, just
The hook?
just for a couple more questions. if
Yeah,
possible,
okay.
And then, maybe 2 or 3 minutes, and then
Sure.
we'll get them out.
And then you'll be in with the hook.
Patty is already finished.
Oh,
She sped through her presentation, and I'm waiting.
we got a little bit of a late start, so, okay. All right, we're almost done. Any other questions, you guys?
I got a question.
Yes.
My brother, right, it's interesting, like, when we're taking a ride in the car, right, and we hear music, he can sing the music and the songs, but yet he can't talk.
Because that's automatic.
Is that what it is?
Uh-huh.
Okay, I'm trying to think.
He
of
could
it.
probably
Is it different
count to,
one?
he could probably count to 10. He could probably say the days of the week. He could
Right,
probably
right.
do the alphabet.
Right.
The things that are automatic.
Is that what it is?
No,
I'm sorry.
they taught me
Sing.
singing.
Singing.
Sing in graders
Okay.
for speech
For the, oh.
Yeah.
therapy.
Corny, but just to talk, like,
No.
Sing.
his speech is much better than it was 5 months ago. And when it first was really rough, one of the tools was
Was
to
the
sing.
That's, I'm gonna try
So,
that.
I mean,
That's
it's really hokey because
No,
it's
no, I think
I
it's
want a
good.
shower,
Yeah.
it
No, but I like
actually
that.
It's called melodic intonation
I like
therapy.
that, I like that.
That
I'm
and the
gonna
other
try
was
that.
the
I'm gonna try
tapping.
that.
Yep. Tapping is called pacing.
Right.
Like I said, we could do a whole day conference on, you know what I mean, speech and swallowing, because there's so many things. Right, pacing board. One word, one tap for every word. Mm-hmm. Oh, yeah.
I hate to do it to you, but
That's okay. All right, we have to leave, folks. Some other people have to come in.
Because maybe I should stay.
I want to thank you very much.
Sure. Okay, thank you. I'm sorry I didn't get to you.
No problem.
Thank you, Stan.